Hi, Ruben here and welcome to Anatomy Movement, where anatomy becomes funatomy. We have summarized and detailed notes, acronyms, HD images to build your photographic memory, X-rays images, tabled notes and questions and answers at the end of each video to help you remember all that we have learned. Without further ado, let's dive into today's topic. The upper limb. We shall look at the following areas in the upper limb: segments, bones, joints, muscles, anatomical spaces, innervation, arterial supply and finally venous supply. So let's get started. Segments. The upper limb is divided into 5 main segments. The segments include the pectoral region, the shoulder region, the arm, the forearm and the hand. The segments helps to divide the upper limb both structurally and functionally. Bones of the upper limb. The bones of the upper limb include the scapula, the clavicle, the humerus, the ulna, the radius and the bones of the hand. Let us have a quick look at each of them. The scapula. The scapula is also known as the shoulder blade. It articulates with the humerus at the glenohumeral joint, and with the clavicle at the acromioclavicular joint. In doing so, the scapula connects the upper limb to the trunk. The costal anterior surface of the scapula faces the rib cage. It contains a large concave depression over most of its surface, known as the subscapular fossa. The subscapularis originates from this fossa. Originating from the superolateral surface of the costal scapula is the coracoid process. It is a hook-like projection, which lies just underneath the clavicle. 3 muscles attach to the coracoid process: the pectoralis minor, coracobrachialis, and the short head of the biceps brachii. The lateral surface of the scapula faces the humerus. It is the site of the glenohumeral joint, and of various muscle attachments. Its important bony landmarks include glenoid fossa, a shallow cavity, located superiorly on the lateral border. It articulates with the head of the humerus to form the glenohumeral joint. Supraglenoid tubercle, a roughening immediately superior to the glenoid fossa. The place of attachment of the long head of the biceps brachii. Infraglenoid tubercle, a roughening immediately inferior to the glenoid fossa. The place of attachment of the long head of the triceps brachii. The posterior surface of the scapula faces outwards. It is a site of origin for the majority of the rotator cuff muscles of the shoulder. It is marked by spine, the most prominent feature of the posterior scapula. It runs transversely across the scapula, dividing the surface into 2. Acromion, projection of the spine that arches over the glenohumeral joint and articulates with the clavicle at the acromioclavicular joint. Infraspinous fossa, the area below the spine of the scapula. It displays a convex shape. The infraspinatus muscle originates from this area. Supraspinous fossa, the area above the spine of the scapula. It is much smaller than the infraspinous fossa, and is more convex in shape. The supraspinatus muscle originates from this area. The scapula has 2 main articulations. Glenohumeral joint, between the glenoid fossa of the scapula and the head of the humerus. Acromioclavicular joint, between the acromion of the scapula and the clavicle. Quiz. What name is given to the concave depression on the costal surface of the scapula? Subscapular fossa, infrascapular fossa, suprascapular fossa, glenoid fossa. The correct answer is subscapular fossa. The clavicle. The clavicle is a slender bone with an S shape. Facing forward, the medial aspect is convex, and the lateral aspect concave. It can be divided into a sternal end, a shaft and an acromial end. The clavicle has 3 main functions. Attaches the upper limb to the trunk as part of the shoulder girdle. Protects the underlying neurovascular structures supplying the upper limb. Transmits force from the upper limb to the axial skeleton. Sternal or medial end. The sternal end contains a large facet, for articulation with the manubrium of the sternum at the sternoclavicular joint. The inferior surface of the sternal end is marked by a rough oval depression for the costoclavicular ligament, a ligament of the SC joint. Shaft. The shaft of the clavicle acts a point of origin and attachment for several muscles: deltoid, trapezius, subclavius, pectoralis major, sternocleidomastoid and sternohyoid. Acromial or lateral end. The acromial end houses a small facet for articulation with the acromion of the scapula at the acromioclavicular joint. It also serves as an attachment point for two ligaments. Conoid tubercle, attachment point of the conoid ligament, the medial part of the coracoclavicular ligament. Trapezoid line, attachment point of the trapezoid ligament, the lateral part of the coracoclavicular ligament. The coracoclavicular ligament is a very strong structure, effectively suspending the weight of the upper limb from the clavicle. A 22-year-old man sustains a displaced clavicular fracture after falling off his bicycle. He undergoes an open reduction and internal fixation of the fracture. Which of the following nerves is most at risk of iatrogenic damage during this procedure? Axillary, suprascapular, supraclavicular, accessory. The correct answer is supraclavicular. The humerus. The humerus is a long bone of the upper limb, which extends from the shoulder to the elbow. The proximal aspect of the humerus articulates with the glenoid fossa of the scapula, forming the glenohumeral joint. Distally, at the elbow joint, the humerus articulates with the head of the radius and trochlear notch of the ulna. The proximal humerus is marked by a head, anatomical neck, surgical neck, greater and lesser tuberosity and intertubercular sulcus. The greater tuberosity is located laterally on the humerus and has anterior and posterior surfaces. It serves as an attachment site for three of the rotator cuff muscles, supraspinatus, infraspinatus and teres minor. The lesser tuberosity is much smaller, and more medially located on the bone. It only has an anterior surface. It provides attachment for the last rotator cuff muscle, the subscapularis. Separating the two tuberosities is a deep groove, known as the intertubercular sulcus. The tendon of the long head of the biceps brachii emerges from the shoulder joint and runs through this groove. Pectoralis major, teres major and latissimus dorsi insert on the lips of the intertubercular sulcus. On the lateral side of the humeral shaft is a roughened surface where the deltoid muscle attaches. This is known as the deltoid tuberosity. The radial or spiral groove is a shallow depression that runs diagonally down the posterior surface of the humerus, parallel to the deltoid tuberosity. The radial nerve and profunda brachii artery lie in this groove. The following muscles attach to the humerus along its shaft. Anteriorly, coracobrachialis, deltoid, brachialis, brachioradialis. Posteriorly, medial and lateral heads of the triceps. The spiral groove demarcates their respective origins. Distally, the trochlea is located medially, and extends onto the posterior aspect of the bone. Lateral to the trochlea is the capitulum, which articulates with the radius. Also located on the distal portion of the humerus are three depressions, known as the coronoid, radial and olecranon fossae. They accommodate the forearm bones during flexion or extension at the elbow. Articulations. The proximal region of the humerus articulates with the glenoid fossa of the scapula to form the glenohumeral joint, shoulder joint. Distally, at the elbow joint, the capitulum of the humerus articulates with the head of the radius and the trochlea of the humerus articulates with the trochlear notch of the ulna. Quiz. Which injury to the humerus is most likely to cause the clinical sign shown? Anatomical neck fracture, surgical neck fracture, midshaft fracture, epicondylar fracture. The correct answer is midshaft fracture. The ulna. The ulna is a long bone in the forearm. It lies medially and parallel to the radius, the second of the forearm bones. The ulna acts as the stabilizing bone, with the radius pivoting to produce movement. Proximally, the ulna articulates with the humerus at the elbow joint. Distally, the ulna articulates with the radius, forming the distal radio-ulnar joint. The proximal end of the ulna articulates with the trochlea of the humerus. To enable movement at the elbow joint, the ulna has a specialized structure, with bony prominences for muscle attachment. Important landmarks of the proximal ulna are the olecranon, coronoid process, trochlear notch, radial notch and the tuberosity of ulna. Olecranon, a large projection of bone that extends proximally, forming part of trochlear notch. It can be palpated as the tip of the elbow. The triceps brachii muscle attaches to its superior surface. Coronoid process, this ridge of bone projects outwards anteriorly, forming part of the trochlear notch. Trochlear notch, formed by the olecranon and coronoid process. It is wrench-shaped, and articulates with the trochlea of the humerus. Radial notch, Located on the lateral surface of the trochlear notch, this area articulates with the head of the radius. Tuberosity of ulna, a roughening immediately distal to the coronoid process. It is where the brachialis muscle attaches. The ulnar shaft is triangular in shape, with 3 borders and 3 surfaces. As it moves distally, it decreases in width. The 3 surfaces. Anterior, site of attachment for the pronator quadratus muscle distally. Posterior, site of attachment for many muscles. Medial, unremarkable. The 3 borders. Posterior, palpable along the entire length of the forearm posteriorly. Interosseous, site of attachment for the interosseous membrane, which spans the distance between the 2 forearm bones. Anterior, unremarkable. The distal end of the ulna is much smaller in diameter than the proximal end. It is mostly unremarkable, terminating in a rounded head, with distal projection, the ulnar styloid process. The head articulates with the ulnar notch of the radius to form the distal radio-ulnar joint. Quiz: what area on the ulna articulates with the head of the radius? Trochlear notch. Radial notch. Ulcranon. Radial process. The correct answer is radial notch. The radius is a long bone in the forearm. It lies laterally and parallel to ulna, the second of the forearm bones. The radius pivots around the ulna to produce movement at the proximal and distal radio-ulnar joints. The radius articulates in 4 places. Elbow joint, partly formed by an articulation between the head of the radius and the capitulum of the humerus. Proximal radio-ulnar joint, an articulation between the radial head and the radial notch of the ulna. Wrist joint, an articulation between the distal end of the radius and the carpal bones. Distal radio-ulnar joint, an articulation between the ulnar notch and the head of the ulna. The proximal end of the radius has a head, neck and tuberosity. The radial shaft expands in diameter as it moves distally. Much like the ulna, it is triangular in shape, with 3 borders and 3 surfaces. In the middle of the lateral surface, there is a small roughening for the attachment of the pronator teres muscle. In the distal region, the radial shaft expands to form a rectangular end. The lateral side projects distally as the styloid process. In the medial surface, there is a concavity, called the ulnar notch, which articulates with the head of ulna, forming the distal radio-ulnar joint. The distal surface of the radius has 2 facets, for articulation with the scaphoid and lunate carpal bones. This makes up the wrist joint. Quiz: which of the following bones does the radius articulate with? Ulna, humerus, scaphoid, pisiform. The correct answer is pisiform. Bones of the hand. The bones of the hand provide support and flexibility to the soft tissues. They can be divided into 3 categories. Carpal bones, a set of 8 irregularly shaped bones. These are located in the wrist area. Metacarpals, there are 5 metacarpals, each one related to a digit. Phalanges, the bones of the fingers. Each finger has 3 phalanges, except for the thumb, which has 2. The carpal bones are a group of 8, irregularly shaped bones. They are organized into 2 rows, proximal and distal. Proximal rows from lateral to medial include scaphoid, lunate, triquetrum and pisiform. Distal row from lateral to medial include trapezium, trapezoid, capitate, hamate. Proximally, the scaphoid and lunate articulate with the radius to form the wrist joint, also known as the radiocarpal joint. In the distal row, all of the carpal bones articulate with the metacarpals. The metacarpal bones articulate proximally with the carpals, and distally with the proximal phalanges. They are numbered, and each associated with a digit, e.g. Metacarpal 1, thumb. The phalanges are the bones of the fingers. The thumb has a proximal and distal phalanx, while the rest of the digits have proximal, middle and distal phalanges. Quiz: which of the following is not located in the proximal rows of the carpal bones? Scaphoid, lunate, trapezium, pisiform. The correct answer is trapezium. Joints of the upper limb. The joints of the upper limb include acromioclavicular joint, sternoclavicular joint, shoulder joint, elbow joint, radio-ulnar joint, wrist joint, metacarpophalangeal joint and proximal interphalangeal joint. The acromioclavicular joint is an articulation in the shoulder region between the clavicle and the acromion of the scapula. It is a plane-type synovial joint. The acromioclavicular joint consists of an articulation between the lateral end of the clavicle and the acromion of the scapula. The joint capsule of the acromioclavicular joint encloses the two articular surfaces. It consists of a loose layer of fibrous tissue, which is lined internally by a synovial membrane. The posterior aspect of the joint capsule is reinforced by fibers from the trapezius muscle. There are three main ligaments that strengthen and stabilize the acromioclavicular joint. Acromioclavicular ligament runs horizontally from the acromion to the lateral clavicle. It covers the joint capsule, reinforcing its superior aspect. Conoid ligament runs vertically from the coracoid process of the scapula to the conoid tubercle of the clavicle. Trapezoid ligament runs from the coracoid process of the scapula to the trapezoid line of the clavicle. The conoid and trapezoid ligaments are collectively known as the coracoclavicular ligament. The acromioclavicular joint allows a gliding movement in the superior, inferior and anteroposterior planes, along with a small amount of axial rotation. As no muscle acts directly on the joint, all movements are passive, and are initiated by movement at other joints. The arterial supply to the acromioclavicular joint is via the suprascapular artery, arises from the subclavian artery at the thyrocervical trunk. Thoracoacromial artery arises from the axillary artery. The venous drainage accompanies the major arteries. The acromioclavicular joint is innervated by articular branches of the suprascapular and lateral pectoral nerves. They both arise directly from the brachial plexus. Quiz: which type of synovial joint is the acromioclavicular joint? Plane joint, hinge joint, saddle joint, ellipsoid joint. The correct answer is plane joint. The sternoclavicular joint is an articulation between the clavicle and the manubrium of the sternum. It is a saddle-type synovial joint which acts to link the upper limb with the trunk. Anatomical structure. Articulating surfaces. The sternoclavicular joint is formed by an articulation between three structures. Sternal end of the clavicle. Manubrium of the sternum. First costal cartilage. Cartilage associated with the first rib. The articular surfaces are covered with fibrocartilage as opposed to hyaline cartilage, present in the majority of synovial joints. The joint is separated into two compartments by a fibrocartilaginous articular disc. The joint capsule of the sternoclavicular joint extends to the borders of the articular surfaces. It is lined internally by a synovial membrane, which produces synovial fluid to reduce friction between the articulating structures. The ligaments of the sternoclavicular joint provide much of its stability. There are four main ligaments. Sternoclavicular ligaments, anterior and posterior, reinforces the joint capsule anteriorly and posteriorly. Interclavicular ligament attaches to the sternal end of both clavicles and reinforces the joint capsule superiorly. Costoclavicular ligament attaches the first rib and costal cartilage to the inferior surface of the clavicle. It is the main stabilizing force for the joint, resisting elevation of the pectoral girdle. The sternoclavicular joint has a large degree of mobility, with several movements possible. Elevation of the shoulders, shrugging the shoulders or abducting the arm over 90. Depression of the shoulders, drooping shoulders or extending the arm at the shoulder behind the body. Protraction of the shoulders, moving the shoulder girdle anteriorly. Retraction of the shoulders, moving the shoulder girdle posteriorly. Rotation, when the arm is raised over the head, the clavicle rotates passively as the scapula rotates. The sternoclavicular joint is required to be both mobile to accommodate the movements of the upper limb and strong to form a stable connection between the upper limb and the trunk. Here we will consider the factors which contribute to both its mobility and its stability. Mobility. Type of joint. Being a saddle joint, it can move in two axes. Articular disc. This allows the clavicle and the manubrium to slide over each other more freely, allowing for rotation and movement in a third axis. Stability. Joint capsule, thick and strong. Ligaments, particularly the costoclavicular ligament, which transfers forces from the clavicle to the manubrium via the costal cartilage. Blood supply. The arterial supply to the sternoclavicular joint is from the internal thoracic artery and the suprascapular artery. Innervation. The sternoclavicular joint is supplied by the medial supraclavicular nerve and the nerve to subclavius. Quiz. Among the listed structures, which one does not contribute to the articulating surface of the sternoclavicular joint? Manubrium. Medial end of clavicle. First costal ridge. Xiphoid process. The correct answer is xiphoid process. The shoulder joint, glenohumeral joint, is an articulation between the scapula and the humerus. It is a ball and socket type synovial joint, and one of the most mobile joints in the human body. Anatomical structure. Articulating surfaces. The shoulder joint is formed by an articulation between the head of the humerus and the glenoid cavity or fossa of the scapula. This gives rise to the alternate name for the shoulder joint, the glenohumeral joint. Like most synovial joints, the articulating surfaces are covered with hyaline cartilage. The head of the humerus is much larger than the glenoid fossa, giving the joint a wide range of movement at the cost of instability. To reduce the disproportion in surfaces, the glenoid fossa is deepened by a fibrocartilage rim, called the glenoid labrum. Joint capsule. The joint capsule is a fibrous sheath which encloses the structures of the joint. It extends from the anatomical neck of the humerus to the border or rim of the glenoid fossa. The joint capsule is lax, permitting greater mobility, particularly abduction. The synovial membrane lines the inner surface of the joint capsule and produces synovial fluid to reduce friction between the articular surfaces. Ligaments. Ligaments play an important role in stabilizing the shoulder joint. Glenohumeral ligaments, superior, middle and inferior, extend from the humerus to the glenoid fossa, reinforcing the joint capsule. They act to stabilize the anterior aspect of the joint. Coracohumeral ligament extends from the base of the coracoid process to the greater tubercle of the humerus. It supports the superior part of the joint capsule. Transverse humeral ligament extends between the two tubercles of the humerus. It holds the tendon of the long head of the biceps in the intertubercular groove. Coracoacromial ligament extends between the acromion and coracoid process of the scapula, forming an arch-like structure over the shoulder joint, coracoacromial arch. This resists superior displacement of the humeral head. Bursae. A bursa is a synovial fluid-filled sac, which acts as a cushion between tendons and other joint structures. There are several bursae present in the shoulder joint. Subacromial, located deep to the deltoid and acromion, and superficial to the supraspinatus tendon and joint capsule. It reduces friction beneath the deltoid, promoting free motion of the rotator cuff tendons. Subscapular, located between the subscapularis tendon and the scapula. It reduces friction on the tendon during movement at the shoulder joint. Movements. The shoulder joint is an extremely mobile joint, with a wide range of movement possible. Extension upper limb backwards in sagittal plane, posterior deltoid, latissimus dorsi and teres major. Flexion upper limb forwards in sagittal plane, pectoralis major, anterior deltoid and coracobrachialis. Biceps brachii weakly assists in forward flexion. Abduction upper limb away from midline in coronal plane. The first 0 to 15 degrees of abduction is produced by the supraspinatus. The middle fibers of the deltoid are responsible for the next 15 to 90 degrees. Past 90 degrees, the scapula needs to be rotated to achieve abduction, that is carried out by the trapezius and serratus anterior. Adduction upper limb towards midline in coronal plane, pectoralis major, latissimus dorsi and teres major. Internal rotation towards the midline, so that the thumb is pointing medially, subscapularis, pectoralis major, latissimus dorsi, teres major and anterior deltoid. External rotation away from the midline, so that the thumb is pointing laterally, infraspinatus and teres minor. Circumduction, moving the upper limb in a circle, produced by a combination of the movements described above. Mobility and stability. The shoulder joint is one of the most mobile in the body, at the expense of stability. Here, we shall consider the factors that permit movement, and those that contribute towards joint structure. Mobility. Type of joint, ball and socket joint. Bony surfaces, shallow glenoid cavity and large humeral head. There is a 1:4 disproportion in surfaces. A commonly used analogy is the golf ball and tee. Joint capsule, lax. Stability. Rotator cuff muscles surround the shoulder joint, attaching to the tuberosities of the humerus, whilst also fusing with the joint capsule. The resting tone of these muscles act to compress the humeral head into the glenoid cavity. Glenoid labrum, a fibrocartilaginous ridge surrounding the glenoid cavity. It deepens the cavity and creates a seal with the head of humerus, reducing the risk of dislocation. Ligaments act to reinforce the joint capsule and form the coracoacromial arch. Biceps tendon, it acts as a minor humeral head depressor, thereby contributing to stability. Blood supply. The shoulder joint is supplied by the anterior and posterior circumflex humeral arteries, which are both branches of the axillary artery. There are also contributions from the suprascapular artery, itself a branch of the thyrocervical trunk. Innervation. Sensory innervation to the shoulder joint is from the axillary and suprascapular nerves, the elbow joint. The elbow is the joint connecting the upper arm to the forearm. It is classed as a hinge-type synovial joint. Articulating surfaces. The elbow joint consists of two separate articulations: trochlear notch of the ulna and the trochlea of the humerus. Head of the radius and the capitulum of the humerus. Like all synovial joints, the elbow joint has a capsule enclosing the joint. This in itself is strong and fibrous, strengthening the joint. The joint capsule is thickened medially and laterally to form collateral ligaments, which stabilize the flexing and extending motion of the arm. There are many bursae in the elbow, but only a few have clinical importance. Intratendinous olecranon, located within the tendon of the triceps brachii. Subtendinous olecranon, between the olecranon and the tendon of the triceps brachii, reducing friction between the two structures during extension and flexion of the arm. Subcutaneous olecranon bursa, between the olecranon and the overlying connective tissue, implicated in olecranon bursitis. Ligaments. The joint capsule of the elbow is strengthened by ligaments medially and laterally. The radial collateral ligament is found on the lateral side of the joint, extending from the lateral epicondyle, and blending with the annular ligament of the radius, a ligament from the proximal radio-ulnar joint. The ulnar collateral ligament originates from the medial epicondyle, and attaches to the coronoid process and olecranon of the ulna. Blood supply. The elbow joint receives a rich arterial supply from a surrounding network of vessels, which is formed by branches of the brachial artery. Innervation. The elbow joint is innervated by branches of the medial, musculocutaneous, radial and ulnar nerves. Movements. The orientation of the bones forming the elbow joint produces a hinge-type synovial joint, which allows for extension and flexion of the forearm. Extension, triceps brachii and anconeus. Flexion, brachialis, biceps brachii, brachioradialis. Quiz. Which of the following is not an articulating surface of the elbow joint? Trochlea, radial head, capitulum, radial tuberosity. The correct answer is radial tuberosity, radio-ulnar joint. The radio-ulnar joints are two locations in which the radius and ulna articulate in the forearm. Proximal radio-ulnar joint, located near the elbow. It is articulation between the head of the radius and the radial notch of the ulna. Distal radio-ulnar joint, located near the wrist. It is an articulation between the ulnar notch of the radius and the ulnar head. Both of these joints are classified as pivot joints, responsible for pronation and supination of the forearm. The proximal radio-ulnar joint is located immediately distal to the elbow joint, and is enclosed within the same articular capsule. It is formed by an articulation between the head of the radius and the radial notch of the ulna. The radial head is held in place by the annular radial ligament, which forms a collar around the joint. The annular radial ligament is lined with a synovial membrane, reducing friction during movement. Movement is produced by the head of the radius rotating within the annular ligament. There are two movements possible at this joint, pronation and supination. Pronation, produced by the pronator quadratus and pronator teres. Supination, produced by the supinator and biceps brachii. This distal radio-ulnar joint is located just proximally to the wrist joint. It is an articulation between the ulnar notch of the radius and the ulnar head. In addition to anterior and posterior ligaments strengthening the joint, there is also a fibrocartilaginous ligament present, called the articular disc. It serves two functions: binds the radius and ulna together, and holds them together during movement at the joint. Separates the distal radio-ulnar joint from the wrist joint. Like the proximal radio-ulnar joint, this is a pivot joint, allowing for pronation and supination. The ulnar notch of the radius slides anteriorly over the head of the ulnar during such movements. Pronation, produced by the pronator quadratus and pronator teres. Supination, produced by the supinator and biceps brachii. Interosseous membrane. The interosseous membrane is a sheet of connective tissue that joins the radius and ulna together between the radio-ulnar joints. It spans the distance between the medial radial border and the lateral ulnar border. There are small holes in the sheet, as a conduit for the forearm vasculature. This connective tissue sheet has three major functions. Holds the radius and ulna together during pronation and supination of the forearm, providing addition stability. Acts as a site of attachment for muscles in the anterior and posterior compartments of the forearm. Transfers forces from the radius to the ulna. Quiz. Which of the following movements occur at the radio-ulnar joints? Pronation, flexion, extension, abduction. The correct answer is pronation. The wrist joint. The wrist joint, also known as the radiocarpal joint, is an articulation between the radius and the carpal bones of the hand. It is condyloid-type synovial joint which marks the area of transition between the forearm and the hand. In this video, we shall look at the anatomy of the wrist joint, its structure, neurovasculature and clinical correlations. Anatomical structure. Articulating surfaces. The wrist joint is formed by an articulation between distal end of the radius and the articular disc. Proximal row of the carpal bones except the pisiform. Together, the carpal bones form a convex surface, which fits into the concave shape of the radius and articular disc. The ulna is prevented from articulating with the carpal bones by the presence of a fibrocartilaginous ligament, the articular disc. Instead, the ulna articulates with the radius just proximal to the wrist, at the distal radio-ulnar joint. Joint capsule. The joint capsule of the wrist joint attaches to the radius, ulna and the proximal row of the carpal bones. It is lined internally by a synovial membrane, which produces synovial fluid to reduce friction between the articulating structures. Ligaments. There are four main ligaments located at the wrist joint. Palmar radiocarpal, located on the palmar anterior side of the joint. It passes from the radius to both rows of carpal bones. Its function, apart from increasing stability, is to ensure that the hand follows the forearm during supination. Dorsal radiocarpal, found on the dorsum posterior side of the hand. It passes from the radius to both rows of carpal bones. It contributes to the stability of the wrist, but also ensures that the hand follows the forearm during pronation. Ulnar collateral, runs from the ulnar styloid process to the triquetrum and pisiform. It acts to prevent excessive radial lateral deviation of the hand. Radial collateral, runs from the radial styloid process to the scaphoid and trapezium. It acts to prevent excessive ulnar medial deviation of the hand. Movements. The wrist is an ellipsoidal condyloid-type synovial joint, allowing for movement along two axes. This means that flexion, extension, adduction and abduction can all occur at the wrist joint. All the movements of the wrist are performed by the muscles of the forearm. Flexion, produced mainly by the flexor carpi ulnaris, flexor carpi radialis, with assistance from the flexor digitorum superficialis. Extension, produced mainly by the extensor carpi radialis longus and brevis, and extensor carpi ulnaris, with assistance from the extensor digitorum. Adduction, produced by the extensor carpi ulnaris and flexor carpi ulnaris. Abduction, produced by the abductor pollicis longus, flexor carpi radialis, extensor carpi radialis longus and brevis. Mobility and stability. The wrist joint is a highly mobile joint to allow the hand to move in several directions. Because of this, the wrist joint is prone to injury. The wrist joint does maintain some stability due to intrinsic and extrinsic ligaments. Intrinsic carpal ligaments, the tiny ligaments between the carpal bones, are short ligaments that provide stability but are easily damaged with excessive force or twisting due to their small size. The extrinsic ligaments, which include the palmar dorsal radiocarpal ligaments and the radial and ulnar collateral ligaments, are stronger and stabilize from the radius and ulna to the carpal bones of the wrist. They are discussed above in further detail. Blood supply. The wrist joint receives blood from branches of the dorsal and palmar carpal arches, which are derived from the ulnar and radial arteries. For more information, see blood supply to the upper limb. Innervation. Innervation to the wrist is delivered by branches of three nerves: median nerve, anterior interosseous branch; radial nerve, posterior interosseous branch; ulnar nerve, deep and dorsal branches. Quiz. Among the listed carpal bones, which one does not contribute to the articulatory surface of the wrist joint? Scaphoid, lunate, triquetrum, trapezium. The correct answer is trapezoid. Muscles. Muscles of the upper limb. The muscles of the upper limb can be grouped in different regions. The regions include muscles of the pectoral region, muscles of the shoulder region, muscles of the upper arm, muscles of the anterior forearm, Muscles of the posterior forearm, and finally muscles of the hand. Muscles of the pectoral region. The pectoral region is located on the anterior chest wall. It contains 4 muscles that exert a force on the upper limb: the pectoralis major, pectoralis minor, serratus anterior and subclavius. In this video, we shall look at the anatomy of the muscles of the pectoral region, their attachments, actions and innervation. Pectoralis major. The pectoralis major is the most superficial muscle in the pectoral region. It is large and fan-shaped, and is composed of a sternal head and a clavicular head. Attachments. Clavicular head originates from the anterior surface of the medial clavicle. Sternocostal head originates from the anterior surface of the sternum, the superior 6 costal cartilages and the aponeurosis of the external oblique muscle. The distal attachment of both heads is onto the intertubercular sulcus of the humerus. Function. Adducts and medially rotates the upper limb and draws the scapula antero-inferiorly. The clavicular head also acts individually to flex the upper limb. Innervation. Lateral and medial pectoral nerves. Pectoralis minor. The pectoralis minor lies underneath its larger counterpart muscle, pectoralis major. Both muscles form part of the anterior wall of the axilla region. Attachments. Originates from the 3rd-5th ribs and inserts into the coracoid process of the scapula. Function. Stabilizes the scapula by drawing it antero-inferiorly against the thoracic wall. Innervation. Medial pectoral nerve. Serratus anterior. The serratus anterior is located more laterally in the chest wall and forms the medial border of the axilla region. Attachments. The muscle consists of several strips, which originate from the lateral aspects of ribs 1 to 8. They attach to the costal, rib-facing, surface of the medial border of the scapula. Function. Rotates the scapula, allowing the arm to be raised over 90 degrees. It also holds the scapula against the ribcage. Innervation. Long thoracic nerve. Subclavius. The subclavius is small muscle, which is located directly underneath the clavicle, running horizontally. It affords some minor protection to the underlying neurovascular structures, e.g. in cases of clavicular fracture or other trauma. Attachments. Originates from the junction of the first rib and its costal cartilage. It inserts onto the inferior surface of the middle third of the clavicle. Function. Anchors and depresses the clavicle. Innervation. Nerve to subclavius. Quiz. What is the innervation of the pectoralis major? Medial and lateral pectoral nerves. Intercostal nerves. Long thoracic nerve. Thoracodorsal nerve. The correct answer is medial and lateral pectoral nerves. Muscles of the shoulder region. The muscles of the shoulder are associated with movements of the upper limb. They produce the characteristic shape of the shoulder, and can be divided into 2 groups. Extrinsic, originate from the torso, and attach to the bones of the shoulder, clavicle, scapula or humerus. Intrinsic, originate from the scapula and/or clavicle, and attach to the humerus. Note: there are other muscles that act on the shoulder joint, the muscles of the pectoral region, and the upper arm. In this video, we shall look at the anatomy of the extrinsic muscles of the shoulder, their attachments, innervation, and actions. The extrinsic muscles of the shoulder originate from the trunk, and attach to the bones of the shoulder, the clavicle, scapula, or humerus. They are located in the back, and are also known as the superficial back muscles. The muscles are organized into 2 layers, a superficial layer and a deep layer. Superficial. There are 2 superficial extrinsic muscles, the trapezius and latissimus dorsi. Trapezius. The trapezius is a broad, flat, and triangular muscle. The muscles on each side form a trapezoid shape. It is the most superficial of all the back muscles. Attachments. Originates from the skull, nuchal ligament and the spinous processes of C7-T12. The fibers attach to the clavicle, acromion, and the scapula spine. Actions. The upper fibers of the trapezius elevate the scapula and rotates it during abduction of the arm. The middle fibers retract the scapula and the lower fibers pull the scapula inferiorly. Innervation. Motor innervation is from the accessory nerve. It also receives proprioceptor fibers from C3 and C4 spinal nerves. Clinical relevance. Testing the accessory nerve. The most common cause of accessory nerve damage is iatrogenic, i.e. due to a medical procedure. In particular, operations such as cervical lymph node biopsy or cannulation of the internal jugular vein can cause trauma to the nerve. To test the accessory nerve, trapezius function can be assessed. This can be done by asking the patient to shrug his/her shoulders. Other clinical features of accessory nerve damage include muscle wasting, partial paralysis of the sternocleidomastoid, and an asymmetrical neckline. Latissimus dorsi. The latissimus dorsi originates from the lower part of the back, where it covers a wide area. Attachments. Has a broad origin, arising from the spinous processes of T7-T12, iliac crest, thoracolumbar fossa and the inferior three ribs. The fibers converge into a tendon that attaches to the intertubercular sulcus of the humerus. Actions. Extends, adducts, and medially rotates the upper limb. Innervation. Thoracodorsal nerve. Deep. There are three muscles in this group, the levator scapulae and the two rhomboids. They are situated in the upper back, underneath the trapezius. Levator scapulae. The levator scapulae is a small strap-like muscle. It begins in the neck and descends to attach to the scapula. Attachments. Originates from the transverse processes of the C1-C4 vertebrae and attaches to the medial border of the scapula. Actions. Elevates the scapula. Innervation. Dorsal scapular nerve. Rhomboids. There are two rhomboid muscles, major and minor. The rhomboid minor is situated superiorly to the major. Rhomboid major. Attachments. Originates from the spinous processes of T2-T5 vertebrae. Attaches to the medial border of the scapula, between the scapula spine and inferior angle. Actions. Retracts and rotates the scapula. Innervation. Dorsal scapular nerve. Rhomboid minor. Attachments. Originates from the spinous processes of C7-T1 vertebrae. Attaches to the medial border of the scapula, at the level of the spine of scapula. Actions. Retracts and rotates the scapula. Innervation. Dorsal scapular nerve. Quiz. What nerve innervates the trapezium muscle? Medial pectoral nerve. Axillary nerve. Accessory nerve. Thoracodorsal nerve. The correct answer is accessory nerve. The intrinsic muscles, also known as the scapulohumeral group, originate from the scapula and/or clavicle, and attach to the humerus. There are 6 muscles in this group: the deltoid, teres major, and the 4 rotator cuff muscles, supraspinatus, infraspinatus, subscapularis and teres minor. Deltoid. The deltoid muscle is shaped like an inverted triangle. It can be divided into an anterior, middle and posterior part. Attachments. Originates from the lateral third of the clavicle, the acromion and the spine of the scapula. It attaches to the deltoid tuberosity on the lateral aspect of the humerus. Actions. Anterior fibers, flexion and medial rotation. Posterior fibers, extension and lateral rotation. Middle fibers, the major abductor of the arm takes over from the supraspinatus, which abducts the first 15 degrees. Innervation. Axillary nerve. Teres major. The teres major forms the inferior border of the quadrangular space, the gap, that the axillary nerve and posterior circumflex humeral artery pass through to reach the posterior scapular region. Attachments. Originates from the posterior surface of the inferior angle of the scapula. It attaches to the medial lip of the intertubercular groove of the humerus. Actions. Adducts and extends at the shoulder, and medially rotates the arm. Innervation. Lower subscapular nerve. Rotator cuff muscles. The rotator cuff muscles are a group of 4 muscles that originate from the scapula and attach to the humeral head. Collectively, the resting tone of these muscles acts to pull the humeral head into the glenoid fossa. This gives the glenohumeral joint a lot of additional stability. In addition to their collective function, the rotator cuff muscles also have their own individual actions. Supraspinatus. Attachments. Originates from the supraspinous fossa of the scapula, attaches to the greater tubercle of the humerus. Actions. Abducts the arm 0 to 15-0, and assists deltoid for 15 to 90-0. Innervation. Suprascapular nerve. Infraspinatus. Attachments. Originates from the infraspinous fossa of the scapula, attaches to the greater tubercle of the humerus. Actions. Laterally rotates the arm. Innervation. Suprascapular nerve. Subscapularis. Attachments. Originates from the subscapular fossa, on the costal surface of the scapula. It attaches to the lesser tubercle of the humerus. Actions. Medially rotates the arm. Innervation. Upper and lower subscapular nerves. Teres minor. Attachments. originates from the posterior surface of the scapula, adjacent to its lateral border. It attaches to the greater tubercle of the humerus. Actions: laterally rotates the arm. Innervation: axillary nerve. The upper arm muscles. The upper arm is located between the shoulder joint and elbow joint. It contains 4 muscles, 3 in the anterior compartment: biceps brachii, brachialis, coracobrachialis, and 1 in the posterior compartment: triceps brachii. In this video, we shall look at the anatomy of the muscles of the upper arm, their attachments, innervation and actions. Anterior compartment. There are 3 muscles located in the anterior compartment of the upper arm: biceps brachii, coracobrachialis, and brachialis. They are all innervated by the musculocutaneous nerve. A good memory aid for this is BBC, biceps, brachialis, coracobrachialis. Arterial supply to the anterior compartment of the upper arm is via muscular branches of the brachial artery. Biceps brachii. The biceps brachii is a 2-headed muscle. Although the majority of the muscle mass is located anteriorly to the humerus, it has no attachment to the bone itself. As the tendon of biceps brachii enters the forearm, a connective tissue sheet is given off, the bicipital aponeurosis. This forms the roof of the cubital fossa and blends with the deep fossa of the anterior forearm. Attachments: long head originates from the supraglenoid tubercle of the scapula, and the short head originates from the coracoid process of the scapula. Both heads insert distally into the radial tuberosity and the fossa of the forearm via the bicipital aponeurosis. Function: supination of the forearm. It also flexes the arm at the elbow and at the shoulder. Innervation: musculocutaneous nerve. The bicep tendon reflex test spinal cord segment C6. Coracobrachialis. The coracobrachialis muscle lies deep to the biceps brachii in the arm. Attachments: originates from the coracoid process of the scapula. The muscle passes through the axilla, and attaches the medial side of the humeral shaft, at the level of the deltoid tubercle. Function: flexion of the arm at the shoulder, and weak adduction. Innervation: musculocutaneous nerve. Brachialis. The brachialis muscle lies deep to the biceps brachii, and is found more distally than the other muscles of the arm. It forms the floor of the cubital fossa. Attachments: originates from the medial and lateral surfaces of the humeral shaft and inserts into the ulnar tuberosity, just distal to the elbow joint. Function: flexion at the elbow. Innervation: musculocutaneous nerve, with contributions from the radial nerve. Posterior compartment. The posterior compartment of the upper arm contains the triceps brachii muscle, which has 3 heads. The medial head lies deeper than the other 2, which cover it. Arterial supply to the posterior compartment of the upper arm is via the profunda brachii artery. Triceps brachii. Attachments: long head, originates from the infraglenoid tubercle. Lateral head, originates from the humerus, superior to the radial groove. Medial head, originates from the humerus, inferior to the radial groove. Distally, the heads converge onto one tendon and insert into the olecranon of the ulna. Function: extension of the arm at the elbow. Innervation: radial nerve. A tap on the triceps tendon tests spinal segment C7. Note: in some individuals, the long head of the triceps brachii is innervated by the axillary nerve. Quiz: which nerve innervates the muscles in the anterior upper arm? Median nerve, axillary nerve, radial nerve, musculocutaneous nerve. The correct answer is musculocutaneous nerve. The muscles of anterior forearm. The muscles in the anterior compartment of the forearm are organized into 3 layers. Superficial: flexor carpi ulnaris, palmaris longus, flexor carpi radialis, pronator teres. Intermediate: flexor digitorum superficialis. Deep: flexor pollicis longus, flexor digitorum profundus, and pronator quadratus. This muscle group is associated with pronation of the forearm, flexion of the wrist, and flexion of the fingers. They are mostly innervated by the median nerve, except for the flexor carpi ulnaris and medial half of flexor digitorum profundus, which are innervated by the ulnar nerve, and they receive arterial supply from the ulnar artery and radial artery. In this video, we shall look at the anatomy of the muscles in the anterior compartment of the forearm, their attachments, actions, innervation, and clinical correlations. Superficial compartment. The superficial muscles in the anterior compartment are the flexor carpi ulnaris, palmaris longus, flexor carpi radialis and pronator teres. They all originate from a common tendon, which arises from the medial epicondyle of the humerus. Flexor carpi ulnaris. Attachments. The flexor carpi ulnaris has two origins. The humeral head originates from the medial epicondyle of the humerus with the other superficial flexors, whilst the ulnar head originates from the olecranon of the ulna. The muscle tendon passes into the wrist and attaches to the pisiform bone, hook of Hamate, and base of the fifth metacarpal. Actions: flexion and adduction at the wrist. Innervation: ulnar nerve, palmaris longus. This muscle is absent in about 15% of the population. Attachments: originates from the medial epicondyle, attaches to the flexor retinaculum of the wrist. Actions: flexion at the wrist. Innervation: median nerve, flexor carpi radialis. Attachments: originates from the medial epicondyle, attaches to the base of metacarpals 2 and 3. Actions: flexion and abduction at the wrist. Innervation: median nerve, pronator teres. The lateral border of the pronator teres forms the medial border of the cubital fossa, an anatomical triangle located over the elbow. Attachments: it has two origins, one from the medial epicondyle, and the other from the coronoid process of the ulna. It attaches laterally to the mid-shaft of the radius. Actions: pronation of the forearm. Innervation: median nerve, intermediate compartment. The flexor digitorum superficialis is the only muscle of the intermediate compartment. It can sometimes be classed as a superficial muscle, but in most individuals, it lies between the deep and superficial muscle layers. The muscle is a good anatomical landmark in the forearm. The median nerve and ulnar artery pass between its two heads, and then travel posteriorly. Attachments: it has two heads, one originates from the medial epicondyle of the humerus, the other from the radius. The muscle splits into 4 tendons at the wrist, which travel through the carpal tunnel, and attach to the base of the middle phalanx of the 4 digits. Actions: flexes the metacarpophalangeal joints and proximal interphalangeal joints at the 4 fingers, and flexes at the wrist. Innervation: median nerve, deep compartment. There are 3 muscles in the deep anterior forearm: flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. Flexor digitorum profundus. Attachments: originates from the ulna and associated interosseous membrane. At the wrist, it splits into 4 tendons, that pass through the carpal tunnel and attach to the distal phalanges of the 4 fingers. Actions: it is the only muscle that can flex the distal interphalangeal joints of the fingers. It also flexes at metacarpophalangeal joints and at the wrist. Innervation: the medial half acts on the little and ring fingers is innervated by the ulnar nerve. The lateral half acts on the middle and index fingers is innervated by the anterior interosseous branch of the median nerve. Flexor pollicis longus. This muscle lies laterally to the flexor digitorum profundus. Attachments: originates from the anterior surface of the radius and surrounding interosseous membrane. Attaches to the base of the distal phalanx of the thumb. Actions: flexes the interphalangeal joint and metacarpophalangeal joint of the thumb. Innervation: median nerve, anterior interosseous branch. Pronator quadratus. A square-shaped muscle found deep to the tendons of the flexor digitorum profundus and flexor pollicis longus. Attachments: originates from the anterior surface of the ulna and attaches to the anterior surface of the radius. Actions: pronates the forearm. Innervation: median nerve, anterior interosseous branch. Quiz: where do superficial muscles of the anterior forearm originate? Olecranon of the ulna. Medial epicondyle of the humerus. Lateral epicondyle of the humerus. Deltoid tuberosity. The correct answer is medial epicondyle of the humerus. The muscles of the posterior forearm. The muscles in the posterior compartment of the forearm are commonly known as the extensor muscles. The general function of these muscles is to produce extension at the wrist and fingers. They are all innervated by the radial nerve. The muscles in this compartment are organized into 2 layers, deep and superficial. These 2 layers are separated by a layer of fossa. In this video, we shall look at the anatomy of the muscles in the posterior forearm, their attachments, actions and clinical relevance. Superficial muscles. The superficial layer of the posterior forearm contains 7 muscles. Four of these muscles, extensor carpi radialis brevis, extensor digitorum, extensor carpi ulnaris and extensor digiti minimi, share a common tendinous origin at the lateral epicondyle. Brachioradialis. The brachioradialis is a paradoxical muscle. Its origin and innervation are characteristic of an extensor muscle, but it is actually a flexor at the elbow. The muscle is most visible when the forearm is half pronated, and flexing at the elbow against resistance. In the distal forearm, the radial artery and nerve are sandwiched between the brachioradialis and the deep flexor muscles. Attachments. Originates from the proximal aspect of the lateral supracondylar ridge of humerus, and attaches to the distal end of the radius, just before the radial styloid process. Actions. Flexes at the elbow. Innervation. Radial nerve. Extensor carpi radialis longus and brevis. The extensor carpi radialis muscles are situated on the lateral aspect of the posterior forearm. Due to their position, they are able to produce abduction as well as extension at the wrist. Attachments. The ECRL originates from the lateral supracondylar ridge of the humerus, while the ECRB originates from the lateral epicondyle. Their tendons attach to metacarpal bones 2 and 3. Actions. Extends and abducts the wrist. Innervation. Radial nerve. Extensor digitorum communis. The extensor digitorum is the main extensor of the fingers. To test the function of the muscle, the forearm is pronated, and the fingers extended against resistance. Attachments. Originates from the lateral epicondyle. The tendon continues in the distal part of the forearm, where it splits into 4, and inserts into the extensor hood of each finger. Actions. Extension of the digits at the interphalangeal and metacarpophalangeal joints. Innervation. Radial nerve deep branch. Extensor digiti minimi. The extensor digiti minimi is thought to originate from the extensor digitorum muscle. In some people, these two muscles are fused together. Anatomically, the extensor digiti minimi lies medially to the extensor digitorum. Attachments. Originates from the lateral epicondyle of the humerus. It attaches, with the extensor digitorum tendon, into the extensor hood of the little finger. Actions. Extends the little finger, and contributes to extension at the wrist. Innervation. Radial nerve deep branch. Extensor carpi ulnaris. The extensor carpi ulnaris is located on the medial aspect of the posterior forearm. Due to its position, it is able to produce adduction as well as extension at the wrist. Attachments. Originates from the lateral epicondyle of the humerus, and attaches to the base of metacarpal V. Actions. Extension and adduction of wrist. Innervation. Radial nerve deep branch. Anconeus. The anconeus is situated medially and proximally in the extensor compartment of the forearm. It is blended with the fibers of the triceps brachii, and the two muscles can be indistinguishable. Attachments. Originates from the lateral epicondyle, and attaches to the posterior and lateral part of the olecranon. Actions. Extends and stabilizes the elbow joint. Abducts the ulna. During pronation of the forearm. Innervation. Radial nerve. Clinical relevance. Lateral epicondylitis. Lateral epicondylitis, or tennis elbow, refers to inflammation of the periosteum of the lateral epicondyle. The peak age of onset is 40 to 50 years old. It is caused by repeated use of the superficial extensor muscles, which strains their common tendinous attachment to the lateral epicondyle. Deep muscles. There are 5 muscles in the deep compartment of the posterior forearm: the supinator, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus and extensor indicis. With the exception of the supinator, these muscles act on the thumb and the index finger. Supinator. The supinator lies in the floor of the cubital fossa. It has 2 heads, which the deep branch of the radial nerve passes between. Attachments. It has 2 heads of origin. One originates from the lateral epicondyle of the humerus, the other from the posterior surface of the ulna. They insert together into the posterior surface of the radius. Actions. Supinates the forearm. Innervation. Radial nerve deep branch. Abductor pollicis longus. The abductor pollicis longus is situated immediately distal to the supinator muscle. In the hand, its tendon contributes to the lateral border of the anatomical snuffbox. Attachments. Originates from the interosseous membrane and the adjacent posterior surfaces of the radius and ulna. It attaches to the lateral side of the base of metacarpal eye. Actions. Abducts the thumb. Innervation. Radial nerve posterior interosseous branch. Extensor pollicis brevis. The extensor pollicis brevis can be found medially and deep to the abductor pollicis longus. In the hand, its tendon contributes to the lateral border of the anatomical snuffbox. Attachments. Originates from the posterior surface of the radius and interosseous membrane. It attaches to the base of the proximal phalanx of the thumb. Actions. Extends at the metacarpophalangeal and carpometacarpal joints of the thumb. Innervation. Radial nerve posterior interosseous branch. Extensor pollicis longus. The extensor pollicis longus muscle has a larger muscle belly than the EPB. Its tendon travels medially to the dorsal tubercle at the wrist, using the tubercle as a pulley to increase the force exerted. The tendon of the extensor pollicis longus forms the medial border of the anatomical snuffbox in the hand. Attachments. Originates from the posterior surface of the ulna and interosseous membrane. It attaches to the distal phalanx of the thumb. Actions. Extends all joints of the thumb, carpometacarpal, metacarpophalangeal and interphalangeal. Innervation. Radial nerve posterior interosseous branch. Extensor indicis proprius. This muscle allows the index finger to be independent of the other fingers during extension. Attachments. Originates from the posterior surface of the ulna and interosseous membrane, distal to the extensor pollicis longus. Attaches to the extensor hood of the index finger. Actions. Extends the index finger. Innervation. Radial nerve posterior interosseous branch. Quiz. What is the action of brachioradialis? Elbow extension. Elbow flexion. Shoulder flexion. Wrist pronation. The correct answer is elbow flexion. The muscles of the hand. The muscles that act on the hand can be divided into two groups. Extrinsic muscles, located in the anterior and posterior compartments of the forearm. They control crude movements and produce a forceful grip. Intrinsic muscles, located within the hand itself. They are responsible for the fine motor functions of the hand. In this article, we shall look at the anatomy of the intrinsic muscles of the hand, their attachments, actions and innervation. Thenar muscles. The thenar muscles are three short muscles located at the base of the thumb. The muscle bellies produce a bulge, known as the thenar eminence. They are responsible for the fine movements of the thumb. The median nerve innervates all the thenar muscles. Opponens pollicis. The opponens pollicis is the largest of the thenar muscles, and lies underneath the other two. Attachments. Originates from the tubercle of the trapezium and the associated flexor retinaculum. It inserts onto the lateral margin of the first metacarpal. Actions. Opposes the thumb, by medially rotating and flexing the metacarpal on the trapezium. Innervation. Median nerve recurrent branch. Abductor pollicis brevis. The abductor pollicis brevis forms the anterolateral aspect of the thenar eminence, overlying the opponens pollicis. Attachments. Originates from the tubercles of the scaphoid and trapezium, and from the associated flexor retinaculum. Attaches to lateral side of proximal phalanx of the thumb. Actions. Abducts the thumb. Innervation. Median nerve recurrent branch. Flexor pollicis brevis. The flexor pollicis brevis forms the medial aspect of the thenar eminence. It is described as having a superficial and deep part, although the deep component is variable in size. Attachments. Originates from the tubercle of the trapezium and from the associated flexor retinaculum. Attaches to the base of the proximal phalanx of the thumb. Actions. Flexes the metacarpophalangeal joint of the thumb. Innervation. Median nerve recurrent branch. The deep head is innervated by the deep branch of the ulnar nerve. Hypothenar muscles. The hypothenar muscles form the hypothenar eminence, a muscular protrusion on the medial side of the palm, at the base of the little finger. These muscles are similar to the thenar muscles in both name and organization. The ulnar nerve innervates the muscles of the hypothenar eminence. Opponens digiti minimi. The opponens digit minimi lies deep to the other hypothenar muscles. Attachments. Originates from the hook of hamate and associated flexor retinaculum, inserts into the medial margin of metacarpal 5. Actions. It rotates the metacarpal of the little finger towards the palm, producing opposition. Innervation. Ulnar nerve. Abductor digiti minimi. The abductor digiti minimi is the most superficial of the hypothenar muscle group. Attachments. Originates from the pisiform and the tendon of the flexor carpi ulnaris. It attaches to the base of the proximal phalanx of the little finger. Actions. abducts the little finger. Innervation, ulnar nerve. Flexor digiti minimi brevis. The flexor digiti minimi brevis lies laterally to the abductor digiti minimi in the hand. Attachments, originates from the hook of hamate and adjacent flexor retinaculum, and inserts into the base of the proximal phalanx of the little finger. Actions, flexes the metacarpophalangeal joint of the little finger. Innervation, ulnar nerve. Lumbricals. There are 4 lumbricals in the hand, each associated with a finger. They are very crucial to finger movement, linking the extensor tendons to the flexor tendons. Denervation of these muscles is the basis for the ulnar claw and hand of benediction. Attachments. Each lumbrical originates from a tendon of the flexor digitorum profundus. They pass dorsally and laterally around each finger, and inserts into the extensor hood. Actions. Flexion at the MCP joint and extension at the interphalangeal IP joints of each digit. Innervation. The lateral 2 lumbricals of the index and middle fingers are innervated by the median nerve. The medial 2 lumbricals of the little and ring fingers are innervated by the ulnar nerve. Interossae. The interossae muscles are located between the metacarpal bones of the hand. They can be divided into 2 groups, dorsal and palmar. In addition to their actions of abduction dorsal interossae and adduction palmar interossae of the fingers, the interossae also assist the lumbricals in flexion at the MCP joints and extension at the IP joints. Dorsal interossae. The most superficial of all dorsal muscles, these can be palpated on the dorsum of the hand. There are 4 dorsal interossae muscles. Attachments. Each interossae originates from the lateral and medial surfaces of the metacarpals. They attach into the extensor hood and proximal phalanx of each finger. Actions. Abduction of the digits. Assists in flexion at the metacarpophalangeal joints and extension at the interphalangeal joints. Innervation. Ulnar nerve. Palmar interossae. These are located anteriorly on the hand. There are 3 palmar interossae muscles, although some texts describe a 4th muscle at the base of the proximal phalanx of the thumb. Attachments. Each interossae originates from a medial or lateral surface of a metacarpal, and attaches into the extensor hood and proximal phalanx of same finger. Actions. Adduction of the digits. Assists in flexion at the metacarpophalangeal joints and extension at the interphalangeal joints. Innervation. Ulnar nerve. Other muscles in the palm. There are 2 other muscles in the palm that are not lumbricals or interossae and do not fit in the hypothenar or thenar compartments. Palmaris brevis. The palmaris brevis is a small, thin muscle, found superficially in the subcutaneous tissue of the hypothenar eminence. Attachments. Originates from the palmar aponeurosis and flexor retinaculum, attaches to the dermis of the skin on the medial margin of the hand. Actions. Wrinkles the skin of the hypothenar eminence and deepens the curvature of the hand, improving grip. Innervation. Ulnar nerve. Adductor pollicis. The adductor pollicis large triangular muscle with 2 heads. The radial artery passes anteriorly through the space between the 2 heads, forming the deep palmar arch. Attachments. One head originates from metacarpal 3. The other head originates from the capitate and adjacent areas of metacarpals 2 and 3, both attach into the base of the proximal phalanx of the thumb. Actions. Adductor of the thumb. Innervation. Ulnar nerve. Quiz. Which of the following is an intrinsic muscle of the hand? Palmaris longus. Extensor digiti minimi. Adductor pollicis. Extensor pollicis brevis. The correct answer is adductor pollicis. Innervation of the upper limb. The brachial plexus is a network of nerve fibers that supplies the skin and musculature of the upper limb. The brachial plexus has root values C5 to T1. It gives rise to the major nerves of the upper limb. The brachial plexus starts with the roots. The roots give rise to the trunks, which give rise to divisions, which further give rise to cords that finally give rise to the branches. The brachial plexus gives rise to a total of 18 nerves, but we shall discuss the 5 main nerves of the upper limb, which include musculocutaneous nerve, axillary nerve, median nerve, radial nerve and ulna nerve. Musculocutaneous nerve. It supplies to muscles of the anterior arm and the lateral skin of the forearm. Axillary nerve. It comes from the quadrangular space and supplies to the deltoid, and there's minor muscle. It goes round the head of humerus in the surgical neck area, hence this is a common site for injury of the nerve. Median nerve. Innervates most of the flexor muscles in the forearm, the thenar muscles, and the 2 lateral lumbricals associated with the index and middle fingers. Sensory functions. Gives off the palmar cutaneous branch, which innervates the lateral part of the palm, and the digital cutaneous branch, which innervates the lateral 3.5 fingers on the anterior or palmar surface of the hand. Radial nerve. Innervates the triceps brachii, and the muscles in the posterior compartment of the forearm, which are primarily, but not exclusively, extensors of the wrist and fingers. Injury to the nerve would result to wrist drop. That is, the wrist would remain flexed. The nerve may also be injured by those who use crutches to result in crutch palsy. When it is compressed in the shaft of the humerus, especially by drunkards when they lay on the arm, it results to Saturday night palsy. Ulnar nerve. Innervates the muscles of the hand, apart from the thenar muscles and two lateral lumbricals, flexor carpi ulnaris and medial half of flexor digitorum profundus. Sensory functions. Innervates the anterior and posterior surfaces of the medial 1.5 fingers, and associated palm area. Anatomical spaces are places in the body that are not occupied by any tissues. They include the cubital fossa, carpal tunnel, anatomical snuff box, quadrangular space, axilla region, triangular intervals, ulna tunnel, triangular space, ulna cana canal, and the extensor tendon compartment. Here are images showing you the various anatomical spaces of the upper limb. It is important to note the contents of the cubital fossa, which include brachial artery and vein, median nerve, and the biceps brachii tendon. The cubital fossa is an important area for pulsations and withdrawal of blood. The contents of the axilla include axillary artery and vein, cords and branches of brachial plexus, axillary tail, axillary fat, and the axillary lymph nodes. The lymph nodes drain 70% of the breast lymphatics, hence it is a potential area for breast cancer. The axillary nerve arises from the quadrangular space to the deltoid, and there's minor muscles. The carpal tunnel is a clinical area for carpal tunnel syndrome, which is basically the entrapment of median nerve within the carpal tunnel. Arterial supply to the upper limb. The arterial supply to the upper limb is delivered via 5 main vessels proximal to distal. Subclavian artery. The arterial supply to the upper limb begins as the subclavian artery. At the lateral border of the first rib, the subclavian artery enters the axilla, and is renamed the axillary artery. Axillary artery. The axillary artery lies deep to the pectoralis minor and is enclosed in the axillary sheath. At the lower border of the teres major muscle, the axillary artery is renamed the brachial artery. Brachial artery. The brachial artery is a continuation of the axillary artery past the lower border of the teres major. It is the main supply of blood for the arm. The brachial artery proper descends down the arm. As it moves through the cubital fossa, underneath the bicipital aponeurosis, the brachial artery terminates by bifurcating into the radial and ulnar arteries. Radial artery. Radial artery supplies the posterolateral aspect of the forearm. It contributes to anastomotic networks surrounding the elbow joint and carpal bones. Ulnar artery supplies the anteromedial aspect of the forearm. It contributes to an anastomotic network surrounding the elbow joint. Also gives rise to the anterior and posterior interosseous arteries, which supply deeper structures in the forearm. Arterial supply to the hand begins with the ulnar and radial arteries. The ulnar artery enters the hand anteriorly to the flexor retinaculum and laterally to the ulnar nerve. It gives rise to the deep palmar branch and continues laterally across the palm as the superficial palmar arch. The radial artery enters the hand dorsally, crossing the floor of the anatomical snuff box. It then turns medially and travels between the heads of the adductor pollicis muscle. The radial artery supplies a branch to the thumb, the index finger, and to the superficial palmar arch. It then continues as the deep palmar arch. As a result, 2 arterial arches are formed. Superficial palmar arch, located anteriorly to the flexor tendons in the hand and deep to the palmar aponeurosis. It gives rise to the digital arteries, which supply the 4 fingers. Deep palmar arch, located deep to the flexor tendons of the hand. It contributes to the blood supply to the digits and to the wrist joint. Venous drainage to the upper limb. The venous system of the upper limb drains deoxygenated blood from the arm, forearm, and hand. It can be subdivided into the superficial system and the deep system. Superficial veins. The major superficial veins of the upper limb are the cephalic and basilic veins. They are located within the subcutaneous tissue of the upper limb. The deep venous system of the upper limb is situated underneath the deep fossa. It is formed by paired veins, which accompany and lie either side of an artery. In the upper extremity, the deep veins share the name of the artery they accompany. The brachial veins are the largest in size, and are situated either side of the brachial artery. The pulsations of the brachial artery assist the venous return. Veins that are structured in this way are known as vena comitans. Perforating veins run between the deep and superficial veins of the upper limb, connecting the two systems. Quiz: which structure marks the level at which the basilic vein moves from superficial to deep in the upper limb? Cubital fossa, teres major, axilla, clavipectoral triangle. The correct answer is teres major. Thanks for watching. Like and subscribe to Anatomy Movement channel for more.